As I've kind of come along in my practice, I've seen some of the things from the community where I feel like they've been pushed a little bit too far. So that's always a shifting stance as to what I feel comfortable doing an MIS case on. So these are just some of the few kind of learning processes from me trying to integrate it more into my practice and things that I've found to be important into doing it and doing it well. So just wanted to talk briefly through the literature. All of us taking part in this course know that there are really good literature to support doing MIS, and then some of the advantages and disadvantages. We'll talk through some cases as well. So it's a newer technology, really reproducible data to support the use in spine surgery, some serious advantages. So, some people may say if you have these technologies available to you, there are plenty of courses out there in order to go learn. It's just a matter of taking your own time and getting trained up on these things. Why are we still doing open surgery? This is a pretty good literature review where they looked at MIS TLIF, 32 different studies and aggregated the data. All of the things that we have seen, less blood loss, shorter length of stay, has been consistent across all the studies. Obviously we are getting less radiation exposure in our open cases. If you're doing a fluoro MIS case, it is a little radiation heavy, so something to consider. Patients do well in both. I think that a lot of people that do open surgery don't feel like learning the new technology. There's basically if you're looking at 6 months out, the patients do just as well. And they're actually slightly sicker patients, it seems, when you're looking at who gets the open surgery. So again, both are great. There are definitely advantages. In terms of complications, this was an interesting slide. They were kind of on slightly favors MIS. And I think, again, these are really dependent upon the user. So a lot of these come from large institutions where they're really at the cutting edge and, some experts in MIS surgery. So if you look at, MIS across the community, it's probably a little bit higher than this study would suggest from this group of studies. And then, but there are some questions that I still have, rates of arthrodesis. There's just such a wide variety of biologics that are used, bone morphogenic protein, off-label for MIS TLIF, but can be very helpful in achieving a fusion when you have a very limited window to place your graft material in. In this study, they showed that the VAS leg and back scores were significantly lower in all studies in the MIS group. So, clearly there is a patient selection factor. Everybody gets better in both MIS versus open, but the open group has always seemed to be a little bit worse off. And I think as clinicians, we know that there are reasons behind that, but you need to look into those data when you're looking at these studies. And again, we just talked briefly about the community and how things can be different than you'll see in a well-written paper from an academic center. They've actually looked at laminectomy and laminotomy. Again, I don't think this is the greatest study, but they did look at MIS TLIF through a tube versus open traditional laminectomy, and then better patient satisfaction, less blood loss, no real difference in complications, but patients are up and moving faster with better pain scores postoperatively and better outcomes. Again, this is not a midline sparing laminotomy that, some people do kind of mini open. There's a lot of different ways to do a laminectomy. As we become less and less invasive, whether you can get the appropriate decompression, I think is the most important thing. But clearly you can do it with a tubular retractor and kind of unilateral laminotomy with bilateral laminoplasty to decompress the contralateral side. You're saving that muscle dissection on the other side, and that's definitely borne out in the literature. So it's a technique that I like to use, whether it's through a tube or with kind of a mini open approach. I've found that patients have done very well from that, so something that we could definitely integrate into our practice with pretty limited teaching. So this is, a patient of mine. He's a 61-year-old, kind of very active guy, hiker, had radiculitis, radiculopathy, and degenerative disc disease. Decided to do a lateral with perk screws. He's now deep sea fishing and hiking. He's very, very happy. I wish all my patients could be like him. So why are we still doing open surgery? Well, it's not always the most appropriate thing. We've seen some cases here where they've tried to do some lateral corpectomies and perk screws, and a lot of tumor burden in the epidural space left over after that lateral because you're just not getting good visualization of the actual decompression of the spinal cord or canal. So if you're doing a tumor surgery and you're actually working on decompressing that epidural space, you really want to have direct visualization that you've done what you came to do. And we've seen a few tumor surgeries where I think that may have been pushing the boundary of MIS a little bit too far. Some of our major deformity surgeries, I know Neil's online. I've seen some amazing deformity surgeries that he's done through MIS technique. It definitely is a long learning curve, and I think it's something that you need to build up to. So as your MIS techniques get more kind of facile, it's definitely possible, but I would say make sure that that's within the scope of your capabilities when you're able to do it. And if you're needing to do bilateral facetectomies or 3-column osteotomies, you may want to integrate some percutaneous techniques above and below those osteotomies, but you want to make sure that you are getting the appropriate bony resection to get the correction you need, because that's the intent of the surgery. Some pretty severe ankylosis, I think, is something that can be a very serious challenge to doing, especially in MIS TLIF. You need to get release of the facet joints. Sometimes the disc space itself takes a lot of work from both sides of the surgical field to get a true release. And so that may be a limitation to doing an MIS technique. And, complex revisions where, you may be working through a fusion mass. This is just going to be pretty significant challenges, especially if you're newer to some of these techniques. So these are just a couple case examples. Both of these patients came to my clinic on the same day, having had MIS TLIF. Looking back at the films, they were, both put in, subsided like this. So, we have really great new technology that's coming out that can allow you to get really good correction through a very small window. But if you're not using the appropriate techniques, you can put them in without getting the results you're hoping for. And looking at that, I think we all believe in indirect decompression. That's why we use these MIS techniques. I think there's very good literature out there. I know there's a study out of Japan recently that showed consistent, greater than 200% increase in the canal volume following lateral surgery with pre and post-operative MRIs, and sustained all the way out to 2 years. We've all had Juan Uribe here talking through, he's come to our lateral course, and he just really stresses the importance of preserving the end plate whether it's doing a lateral, but the same is true for MIS TLIF as well. If you're doing that case, we saw the patients, here, if you're doing this case and you damage the end plate, you want to have the tactile feedback to know that that's happened, and maybe try a slightly different approach, because you're not actually getting the indirect decompression that you're looking for if you're damaging the end plate when you try to do this technique. So other things with these two patients, no workup for bone density. One was an active smoker. So, these are risk factors that are modifiable that, if you're going to be doing an MIS TLIF, whether it's a lateral or an MIS TLIF, that end plate is just so important to getting that indirect decompression. And if the patient's osteoporotic, that's going to be a very significant limitation to how much height you're going to be able to gain with those implants. Just kind of some things that I've noticed, and obviously we all have injuries to the end plate. That's kind of the softest bone there in the center of the vertebral body in a kind of traditional straight ahead TLIF approach. So if it is damaged, things that you may want to change to, you may want to switch to more of a banana type cage that's going to put it forward onto the apophyseal ring. You don't even need to come to the other side. You can just change your implant and get a much better purchase on the bone. And I think that's something that you can do intraoperatively to kind of salvage one of these if you do find that you've violated the end plates. Again, patients not happy, coming to a different surgeon. Again, you may call this a successful surgery, but, you don't always see it if they go to see someone else because they're not happy with your results. So just things to keep in mind because we all want to see our patients do well. Postoperative radiculitis, was very kind of upset when I had my first one. It's kind of a part of MIS TLIF. People have, said that it's the technique. We're working through Camden's triangle. There's very little room there. Or is it direct kind of irritation of the nerve? Is it the use of BMP? This recent study where they, looked at 223 cases, MIS, open with and without BMP, and both MIS and BMP was significant risk factor for postoperative radiculitis. I think you can cause it both by that kind of chemical irritation and by, banging on the nerve a little bit too much. So again, if you are using BMP in these cases, is something to be aware of and something to discuss with your patients preoperatively. This was a patient who had a postoperative radiculitis and came to see me about a year and a half out from her surgery, had the scan done probably 6 months before I met her, and had a post-op radiculitis and was kind of brushed off a little bit. To me, I felt like that screw might be in the foramen and there could be some, heterotopic bone compressing that nerve. So, I didn't know if it was a, injury from the surgery itself, not totally sure if I would be able to help her very much, but just going in and replacing that screw and trying to remove some of that HO, she was very happy and significantly improved radiculitis. So again, it can happen from the technique, but if your patients are continuing to complain about radiculitis, 6 months later, I think getting higher imaging is very worthwhile because there are other reasons opposed to just kind of the normal postoperative expectations of an MIS TLIF. And standalone lateral, we're looking at being less invasive. If you have a previous fusion, that's one of the least invasive techniques that we can do. They're kind of all across the board in terms of what the subsidence rate is. I've seen up to 32%, so that's kind of something that we'd wonder whether, it's the surgeon technique, whether that's the kind of implant you're using, but again, there has been reported a very high rate of subsidence, and again, you're not going to get that foraminal decompression or the central decompression if you do lose the reduction that you were getting or that elevation of the end plates. I'm afraid of standalone lateral. I'd love to hear from some other people who may have better results with it. But not all subsidence causes recurrent symptoms, and it's definitely significantly less morbid than having to do an adjacent level surgery and a redo operation with all the scar tissue. It's a challenging surgery. So this is another woman who came to me. I don't know if you can see that well, but she has dynamic stabilization. She's got those old, I think they're KT cages. She's had lots of spine surgeries. The surgeon did a standalone lateral above that prior dynamic stabilization, gave her a few months of relief. So that was a kind of left-sided lateral with the peak cage there. Plan was to come back and do an additional right-sided standalone lateral above the previous standalone lateral. And I really just didn't feel that given her overall deformity and the limited results she got from the previous surgery that would be appropriate. So, Again, I'm sure we all have some concerns that this would be an effective treatment for her, but, in my hands, she ended up with a T10 to pelvis, and she's actually very happy. So I'm fortunate that I was a little worried that given all her surgery, she would not be that well improved, but with the improvement of her correction, with the correction of her deformity, she was. So that's just a few thoughts from my end as someone who is trying to become more of a adept MIS surgeon. I think the patient preference is, and I had some more slides here, but just some of the take-home points, preserving, the technique with open surgery, making sure that end plate is intact is really a tactile thing when you're doing these cases. You don't want to be overly aggressive with the shaver. Make sure that you're doing it on the correct patients. Because osteoporotic patients, really ankylosed spine is going to lead to a very challenging case, and so definitely don't start with those. And then, just make sure that you are using the right indications, and it really is a great technique that I've found has been very, very helpful for my patients. So thank you all, and any questions, I'd love to answer them.
I think it was a great talk. I really liked it. So, one thing that you alluded to was really the benefit area of MIS, right? Every procedure has its, we call it also referred to as the sweet spot, right? It's a little bit less technical, but in your hands, where do you see the sweet spot for lateral? Where do you, in your practice, where do you see T-lifts, make the most sense? What is your experience there?
So I think, having the ability to, convert to a T-lift. I had a patient recently that was planning on doing a 4 or 5 lateral with perc screws for bilateral pars fractures. I think that's a great case. But he had a very tight plexus and was getting a lot of feedback from neuromonitoring. So converted that to an MIS T-lift, and again, he's very happy. So I think you definitely want to have that as a, as a backup. Whenever you're considering doing lateral, there are always, challenges with the plexus that you have to have another approach. So it's a great case, but doesn't always work in every patient. Other things I've seen that's really been effective, like even for trauma, like a ankylosing spondylitis with a fracture that's unstable, being able to put perc screws, do a long construct without a lot of tissue damage. There are a lot of great indications, and I think that for every person it's different. I think each one of us is able to expand that kind of area that we feel comfortable doing an MIS case. And again, that's been happening for me, and just trying to learn from other people that have been able to do cases that I wouldn't have thought would work well and have gone well. And, just to be able to know that, with the appropriate techniques, it's not necessarily that the MIS itself is inappropriate, but if you're not doing the MIS technique appropriately, you can have some bad outcomes.
No, that was great. Very good presentation. One of the things you alluded to was maybe some of the limitations of MIS, particularly long segment or severe deformities. And Neil's on the line, so maybe go in, and obviously any of the other panelists. But I think, in my opinion, there's actually a ceiling effect. I mean, it's very clear cut for 1 or 2 level MIS interbody fusions that outcomes are actually quite good. There's a lot of literature behind that. There's a lot of supportive evidence. I think when you go beyond that to like 4, 5, 6 levels, you start to see a ceiling effect, and that may be surgeon specific to a certain extent or technique specific. But I do think that you lose some of the exposure-related morbidity benefits when you go longer segment with MIS cases, and your ability to correct severe deformities starts to decline. And I don't know what your impression of that is, or any of the panelists, but I do think that's definitely a factor. And I think, like Juan Uribe, for example, he will talk about maybe 4 or 5 levels being that kind of limitation where you start to see some of the decline in the benefits. What's your opinion on that?
Yeah, I think it really depends on the indications, because Jens isn't here today, but he's, one of the proponents of the, what he calls an intradiscal osteotomy. And, that's just not really feasible from an MIS approach. And if you're trying to get a lot of correction at a single level, whether it's for a high-grade spondy, he actually puts distractors in both sides and elevates those vertebrae away from one another. Something like that, I think, is not possible to do, even if you do bilateral facetectomies. Just the manipulation that you're trying to get a really big correction, I think definitely there's a limitation to that. And whether it's the amount of correction or the number of levels, it just depending on how much you're trying to get from a level in and of itself, or from doing a 5-level case. I definitely think that that's outside of my comfort level, and it's been true for a lot of other people as well.
I think alluding to that, I think one of the big challenges is doing more than 2-3 levels and getting good arthrodesis at each level. So what is your strategy for good arthrodesis, with MIS?
So I think that especially, with a lateral, I think you have a really good, big cage going in, a lot of surface area for fusion. Taking the extra time for an MIS TLIF to really try to get across to the opposite side. It's very easy to go directly down the tube, put in your shavers, put a little graft there, but you've left kind of probably 2/3 of the disc space open. So using kind of an angular pituitary, making sure that you're staying well behind the annulus and making more space next to where your cage is going to be, and actually filling that space with bone graft. Again, having seen some cases come into my clinic where, there's a lot of HO kind of posterior in the foramen, I'm a little bit gun shy about that. But I know people have had great results with it. If you're very careful, if you put it all the way kind of anterolateral away from where the foramen is, people have not seen that as much. But again, I think that that's very individual, because if you're putting it in a tight window and it's just seeping up into the foramen, then that's when you're going to see that HO. So
do you use a BMP then for your MIS?
I have not been. Yeah.
What do you use?
I've been using just local allograft, whether it's from the doing a contralateral facetectomy, and then putting some cancellous chips or DBM.
Oh, for the laterals.
For laterals, I'll use DBM or cancellous.
Okay, great. Thank you very much.
Thank you.